at equilibrium time. This slide shows the examination result by light microscopy. As you can see in the upper section of this slide, most of oocytes in VSEGP group were surrounded by compact ovarian stroma, similarly to control. On the other hand, a lot of severely damaged oocytes can be seen in VSED group. The proportion of morphologically normal follicles vitrified in VSEGP for 5 minutes was significantly higher than that of follicle vitrified in VSED for 5 minutes. On the other hand, longer exposure time to VSED significantly increased the proportion of morphologically normal follicles, but no differences were observed in between two solutions. This slide shows the examination result by transmission electron microscopy. The proportion of morphologically normal mitochondria in oocytes vitrified after 5 minutes exposure to VSEGP was similar to that in non-vitrified oocytes, and that was significantly greater than in oocytes vitrified after 5 minutes exposure to VSED. So finally, we decided to use the VSEGP solution for 5 minutes at equilibrium time according to the examination result by light microscopy and by transmission electron microscopy. Ethylene glycol is the most commonly used and widely accepted permeable cryoprotectant for vitrification procedures, as you know, and it shows low toxicity but rapid diffusion into cells. Macromolecules such as PVP or the sugar can act as non-permeable cryoprotectants, increasing water withdrawal from cells and decreasing cryoprotectant exposure time. So reduced exposure time to a cryoprotectant is vital to support the viability of oocyte in ovarian tissue. Thereafter, we used vitrification method in 7 cynomolgus monkeys as for the preclinical study. This slide shows the result of systematic estrogen and progesterone levels after heterotopic transplantation using stool vitrification method. The recovery of hormone cycle was confirmed on day 78, and we could confirm the hormone cycle up to day 716 after transplantation. Hormone cycle was also recovered in the other 2 monkeys by stool vitrification. But unfortunately, the size of ovarian tissue was too small to confirm the transplanted size. That was why it was difficult to collect eggs from the transplanted site. Therefore, we established a new device, cryosupport. The size of the ovarian tissues for this new device is 1 centimeter in height, 1 centimeter in width, and 1 to 2 millimeter thickness. Next, I will show the data using this new device. As you can see in this slide, we could also confirm the recovery of hormone cycle by this new device, cryosupport vitrification. Finally, no differences was seen in recovery of hormone cycle between 2 methods. This table lists experimental result using vitrified ovarian cortex from 7 monkeys. The median duration for which transplanted ovarian tissue recovered to function was 151 days. Finally, we developed a new ovarian tissue vitrification methods using stool and cryosupport. The distribution of blood vessels at the site of heterotopic transplantation was examined by contrast-enhanced CT using monkey number 5 on the day before overcorrection after induced superovulation. The results showed contrast enhancement of the transplanted ovarian tissue present in the mesocervix on the right side of the uterus and in the omentum in the left lower abdomen. Images of developing follicles were observed in the 2 transplanted ovarian tissues. The result of contrast-enhanced CT showed that the blood was supplied from the right uterine artery to the transplanted ovarian tissue in the mesocervix and from the left gastroepiploic artery to the transplanted ovarian tissue in the omentum. This slide shows the 3D CT images, and we can confirm the distribution of newer blood flow to the transplanted ovarian tissue. As you can see in this slide, again, we can confirm the distribution of newer blood flow, uterine artery and gastroepiploic artery. This slide shows a photo of intraperitoneal findings at harvesting of ova on the day after the CT examination. Developing follicles were observed visually in the heterotopically transplanted ovarian tissue with 3 in the omentum, 1 in the left iliac fossa, and 1 in the right mesocervix. Finally, 4 ova was successfully harvested from the omentum and right mesocervix, excluding the developing follicles in the implanted ovarian tissue in the left iliac fossa. Collection of ova was attempted from omentum, mesocervix, retroperitoneal region, and uterine serosa, with 9-2M2 stage ova being successfully harvested from the heterotopically transplanted vitrified ovarian tissue. Microfertilization was performed on the same day and achieving fertilization of 6 ova. To summarize, we established an appropriate method of transplantation using ovarian tissue in primate by vitrification. Our findings may also provide useful information for the clinical application of heterotopic transplantation in patients without residual ovaries. Many reports have attempted to compare the slow phasing method and vitrification to determine which is better, but this appears difficult. Morphological investigation alone is not considered sufficient because the endpoint of this technique is to achieve a live birth. A randomized study would be preferable, but clinical research is difficult to conduct in humans. Extrapolating data from rodent to human should also be avoided. We plan to conduct a randomized studies comparing the slow phasing method and vitrification using cynomolgus monkeys, but they are difficult to use for a randomized study because we have no way to count the number of primordial follicles in ovarian tissue before transplantation, and the number of primordial follicles differs with the individual. I myself don't think we need to determine which method is better because the slow phasing method has already widely been used in the United States and Europe since 1998. We are promising this technology of ovarian tissue vitrification that anyone can easily use using handheld device and without resorting to expensive device in an Asian country. Next, I will talk about clinical application of ovarian tissue vitrification and transplantation. The IRB of St. Marian University School of Medicine in Japan approved our clinical study of transplantation using vitrified human ovarian tissue at the end of 2009. Since January 2010, we have performed ovarian tissue vitrification in a total of 164 patients. The details are shown on this slide. As ovaries of breast cancer patients have very little chance of metastasis, and also the incidence of young patients is increasing, I think this method is most suitable for this kind of patients, which is breast cancer. Laparoscopic ovariectomy is performed in 3-day hospitalization. Under laparoscopic surgery, ovariectomy was performed to remove one ovary without using electrocautery hemostasis to avoid damages to residual follicles. Usually, one whole ovary is removed and then cut into the several pieces of the ovarian tissues of the size of the 1 cm in height, 1 cm in width, and 1 millimeter thickness. Ovarian cortex were immediately dissected by removing medulla in medium, followed by cutting into small strips to maximize surface to mass ratio on a warm plate at 37 degrees. We always confirm the follicular presence and minimum residual diseases in the ovarian tissue by HE staining. Vitrolite saw the ovarian tissue is transplanted in fallopian tube, sometimes saw the residual ovary and peritoneum, and a laparoscope. At the time of ovarian sampling, visible follicles can be taken from the ovarian tissue, and then oocyte retrieval is done by follicle trimming. Thereafter, oocytes are grown in culture until the oocytes are mature. For a married patient, oocytes are then fertilized by ICSI being frozen, whereas mature oocytes are frozen for an unmarried patient. We can aspirate follicles from the remaining ovary during operation whenever possible. This table in this slide shows the maturation rate of immature oocyte taken from the ovarian tissue and shows the fertilization rate that were grown and underwent maturation in vitro and were able to be fertilized by ICSI. 168 oocytes became mature out of 398 retrieved oocytes from visible follicles, which size is 2 to 5 millimeter in diameter, and maturation rate was 42.2%. Finally, the fertilization rate in 19 patients was 48.6%. This slide shows that the correlation of AMH level and the number of extracted oocytes. According to our data of 33 cancer patients using combined syrup procedure, the coefficient of extracted oocyte had a statistical association with an AMH level. We have developed a new technology for the premature ovarian insufficiency patients. This becomes a technology that combined with ovarian tissue vitrification, which Dr. Morimoto and I established, and in vitro activation, which Dr. Kawamura, Professor Shuei, and Professor Ishizuka established. Specifically, ovarian tissue vitrification and fragmentation and in vitro activation drug treatment using the PTE inhibitor and PI3 kinase activator is combined, followed by autotransplantation as infertility treatment for POI patients. This slide shows the mechanism of in vitro activation. Ovarian fragmentation disrupts the Hippo signaling pathway in the ovary, leading to increased production of downstream CCN growth factors and the promotion of dormant secondary follicle growth. PTE inhibitors and PI3 kinase stimulators activate dormant murine and human primordial follicles in vitro, according to Dr. Kawamura. We have performed a prospective clinical study of 37 infertile women with POI between 2011 and 2013. You can see the disease of the patients in this slide. Among 37 patients, 54% had residual follicles based on histology. Among patients with follicles, 9 out of 20 showed follicle growth in autografts of vitrified solid ovarian tissue, with 24 oocytes retrieved from the patient. 6 patients. As shown in this slide, based on the clinical data and patient's history, patient age at ovariectomy for vitrification was similar in all groups, but the duration from the diagnosis of POI to ovariectomy was significantly shorter in those patients with residual follicles that respond to IVA treatment. There were no differences of AMH concentrations above a threshold between groups with histological presence and absence of residual follicles. Interestingly, we frequently detect endometriosis in patients with residual follicles and respond to IVA treatment by showing follicle growth. Following IVF and embryo transfer into 4 patients with POI, we finally had 3 successful pregnancies using ovarian tissue vitrification combined with in vitro activation procedure for the POI patient. Fortunately, the second live birth was achieved at the beginning of May 2014. There are 2 advantages if we combine to use these 2 procedures for the POI patient. First, POI is a progressive disease. The number of primordial follicles decreases over time. This makes it recommendable to cryopreserve one ovary or the other to prepare for the future possible in vitro activation. The remaining ovary is then treated with hormones to promote incidental follicular development. And second, with in vitro activation, only part of cryopreserved ovarian tissue slices is captured, and remaining slices are cryopreserved for possible future in vitro activation. For cryopreservation of ovarian tissue, a vitrification method was performed using the OVA cryo device type M kit we established. This is a collaborative research with Dr. Shu Hashimoto and Dr. Yoshiharu Morimoto in IVF Number Clinic, Osaka, Japan. And now 160 vitrified solid ovarian tissue transplantation have been performed in St. Mary's University since 2010. Professor Walsh published a report of the assessment of ovarian tissue cryopreservation in Lancet in 2014. They assessed ovarian tissue cryopreservation in 410 patients with adolescent and young adult cancer according to Edinburgh selection criteria. The incidence of premature menopause was significantly higher in those who underwent ovarian tissue cryopreservation. This hazard ratio is 56.8. 4 of those undergoing ovarian cancer cryopreservation died of their primary disease, while 81 who did not fulfill these criteria died of their primary disease. Risk of transferring malignancy cells with transplanted frozen salt ovarian tissue, which is minimal residual disease in ovarian tissue, is a danger that we should evade most. This showed the risk of ovarian metastasis according to the cancer types reported by Professor Doman in 2013. The risk is classified as high, medium, and low. Low-risk disease include breast cancer, uterine cervical cancer, which is squamous cell carcinoma, and Hodgkin's disease, osteogenic carcinoma, non-genital rhabdomyosarcoma, and Wilms tumor. As shown here, leukemia and non-Hodgkin's lymphoma are not suitable target diseases for ovarian tissue cryopreservation because ovarian metastasis has been confirmed. Carbon graphite sheet permit high cooling and warming rate compared with copper sheet because of its high thermal conductivity. Other researchers in Japan have already developed and marketed devices for vitrified vitrification using copper as material. We attempt to prepare a new device using carbon graphite sheets, which have excellent heat resistance and low temperature resistance, as well as 4 times the thermal conductivity of copper. Investigation of cooling and warming rates shows that carbon graphite sheets have significantly more rapid cooling and warming rates than copper. Next, vitrification with the cryo support and copper or carbon graphite sheet was performed using pig ovarian tissue. The morphology of the ovarian follicles was investigated after HE staining. The cooling and warming rate with the carbon graphite sheet was significantly higher than those with the copper plate. A total of 2,034 follicles were analyzed by light microscopy to evaluate the morphologies of the follicles, vitrified ultra-rapidly with 4 different devices. And the architecture of the compact matrix of ovarian stroma tissue, which consists of stroma cells and bundles of collagen fibers, was damaged most in the specimens frozen using copper plate. There were no differences in morphologies of follicles between cryo support and carbon graphite sheet. Follicle morphologies frozen in the cases of cryo support and carbon graphite sheet were well preserved compared with copper plate, and follicle morphologies in the cases of copper plate were most damaged than those in other devices. Based on these above findings, we prepared a new closed type of vitrification device, which carbon graphite sheet as shown in this slide. All devices we developed for ovarian tissue vitrification are open type devices. As shown here, it is advantageous to have ovarian tissue frozen quickly because ovarian tissue directly conduct liquid nitrogen. But such contact is, of course, a safety concern. It is preferable to develop closed device for ovarian tissue vitrification that frees ovarian tissue as quickly as open devices do. We have thus developed the closed device for ovarian tissue vitrification using carbon graphite sheet. Visualization.
3 minutes.
Okay. By transparent film, and it makes more completely sealed. This enables ovarian tissue slices to be observed while being frozen. As you can see in this slide, it is easy to take ovaries slices from the device since visualization is possible by using transparent film. Okay. So Professor Donay established ovarian tissue cryopreservation and transplantation techniques and made innovations in the field of reproductive medicine, that have given great hope to young women with cancer in Japan. In Japan, Professor Done's work recently began giving such women the possibility of preserving their fertility. So finally, I will introduce this slide. Okay. So young female cancer patients have fear of future due to cancer, as well as fear of the future related to their loss of fertility because they are young. A medical healthcare network should be established in which oncologists and OBGYN doctors have in-depth knowledge about cancer therapy and reproductive medicine, allowing them to educate patients and provide psychological support. However, it should be remembered that appropriate action must be taken for the underlying disease, and cancer therapy should be prioritized. This slide shows the take-home message from today's talk. Ovarian tissue vitrification may be a promising new method for clinical application in the fertility preservation. I really would like to thank Dr. Budi Bebiko for preparing a strong collaboration between your team and my team. Dr. Ahmad Kemal Hatif joined in our team and performed doing research regarding POI with Kazuhiro Kamura for 3 months in 2014. Since September 2014, Dr. Mira Maidardi came to join in our team, and she is now doing research regarding ovarian tissue vitrification and basic research in fertility preservation as a research fellow. It's a great pleasure to be with them in Japan and to have wonderful collaboration with Indonesia. Once again, I'd like to thank Andong for giving me such a wonderful time. Terima kasih. Thank you very much.
Thank you very much, Professor Suzuki. Please have a seat here. So time for the discussion. Probably we can address 2 or 3 questions. But do you want to have there, or you can have it here? Okay, please. Yes, Dr. Kanadi. Yes, please. Is there any microphone? This is very interesting topics. Yes.
Yes, thank you very much for your excellent talk. Well, I do really interested on the primary ovarian insufficiency patients. So could you explain again the idea how to activate again the follicle response by taking out the ovary and then do the cryopreservation and then slice them into fragments. So how that procedure can reactivate the response of the follicles.
Okay.
And my second question also, is there any issue about reperfusion injury when you put back again the cortex of the cryopreserved ovary to the particular site inside the abdomen, because there is no particular procedure to do anastomosis with the blood vessels. Thank you.
First one, actually, that procedure was established by Dr. Kawamura and Dr. Professor Shue, and the fragmentation activate hippo signaling pathway that immediately activate the secondary follicular growth, and after that, P10 inhibitor and PI3 kinase, some kind of drugs put into the medium, and that accelerate and activate the primordial follicular growth. So that's the way that we combined the ovarian tissue cryopreservation and in vitro activation using fragmentation and P10 inhibitor and PI3 kinase activation. Is that okay? And so how to get the new vessels? Yeah, very hard questions. So some group in Europe put the VEGF factors before the implant ovarian tissue, and Professor Donay just cut the peritoneum 1 week before the implantation day. And then 1 week, which means 7 days, makes the vascularity to receive easily to have the ovarian tissue. But in our case, we don't do that kind of procedure. We are using just mesosalpinx of the fibria because that have lots of vessel networks. So then it works. That's why we don't put any drugs and we don't do such procedure before implantation. Is that okay?
Yes, thank you.
So very good. Is there any other question? I have one. Yes, please, Dr. Relly. Please. Microphone.
Thank you, Dr. Andon and Professor Suzuki. How this of the ovarian transplantation is from the carcinogenic portion is offspring, the baby, the possibility to get also the malignancy. How you can to eliminate the possibility that the malignancy from the mother to the baby, because one of the malignancy causes the genetic, then maybe you can how to screen the patient that the possibility to get pregnancy in the baby.
Thank you very much. This is very important question. So we cannot prevent the cancer, like reintroduction of the cancer cells to the mother. So that's why the criteria is most important. Criteria means like leukemia and non-Hodgkin lymphoma cells. Sometimes it's in the ovarian tissue. We call minimum residual diseases. Then in that case, if we implant the ovarian tissues with leukemia person, we can reintroduce cancer cells into the mother. Then in that case, we cannot prevent anything. That's why the criteria is very important. Is that okay? So actually, the answer is now we cannot prevent, but we should obey the strict criteria. Is that okay?
Jadi ada kriteria khusus, dia tidak bisa mencegah bahwa sel kanker itu akan ikut transplantasi. So there is a special criteria for that before we can transplant the tissue, from the preserved tissue go to the mother. Is there any also what about for the offspring, for the outside? Then retrieve from this transplantation. Also there is a possibility to have cancer to the child or to the baby. No.
And in other ways, we can inoculate ovarian tissue to the nude mice to see what happens, like in 6 months. If something happens, which means the cancer cells growing in the inoculated ovarian tissue in the nude mice. But anyway, we should obey is okay? The strict criteria.
Okay. Yes, due to limitation of the time, I would like to close this session. I would like to say thank you very much to Professor Suzuki. Thank you very much again. Thank you very much. Baik, dengan berakhirnya sesi ini, saya kembalikan ke panitia.
Terima kasih.
Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih kepada moderator Dr. Andon Hestiantoro SPOG Konsultan, and thank you for Prof. 00009Suzuki as a speaker. Demikianlah rangkaian acara kita pada hari pertama pertemuan ilmiah berkala HIFERI 2015. Semoga bermanfaat untuk kita semua. Terima kasih atas kehadiran Bapak Ibu.